So I'll be talking about paediatric fractures. So first starting off with the anatomical differences between adult and child bones. So adult bones only contain a diaphysis and metaphysis. And child bone contain the growth plate and the epiphysis. Oh, the words. This is due to the ossification of the epiphysis and the closure of the physis. Children, they have much thicker periosteum as they are more vascular, and this causes quicker healing time. So the biomechanical differences: children bones are weaker, but they're more compliant, so they're more likely to bend than break, and this is due to the decreased osteodensity. They're more porous than adult bones as they have more Haversian canals, and the Haversian canals occupy a much greater part of the bone. You can also use this mnemonic to estimate the age of a skeletal bone for the elbow, but it's also good to telling whether a part of the bone is of normal growth or it's a fracture or something pathological. So this is an estimate of when these ossification centres should appear, but boys and girls do grow at different ages, so they're not exact. But at first year, they should have the capitellum. 3 years, they should have the radius. 5 years, the internal epicondyle or medial. 7 years, the trochlea. 9 years, the olecranon. And 11 years, the external epicondyle. So what are fractures? Fractures occur when the loading force exceeds the load-bearing capacity. The fracture pattern depends upon the force of the injury and the properties of the bone involved. So the most common causes are trauma, osteoporosis, and overuse. You may also get conditions to the underlying tissues from fracture. This is seen in open fractures, where the skin or another surface has been pierced either by broken bone or the accident that caused the fracture. This represents orthopedic emergency requiring immediate irrigation and debridement. They may require IV antibiotics, and it is associated with high risk of compartment syndrome, neurovascular injury, and other soft tissue injuries. So common types of fractures you may see is transverse, where the broken piece of bone is at a right angle at the bone's axis. Linear, the break is parallel to the bone's long axis. Oblique non-displace, where the bone breaks but does not move out of alignment. Then you have displace, where it breaks in two or more places and moves out of alignment. You have spiral, where one of the bones has been twisted at the break point. Green stick, which is common in children, is an incomplete fracture where the bone is bent. Comminuted is where the fracture the bone breaks into several pieces. Avulsion is when the fragment of bone separates from the main mass. And then stress is a hairline fracture, and it's common in athletes or osteoporosis. And then finally, buckled or impacted, where ends are driven into each other and are commonly seen in arm fractures in children. Another way to classify fractures in children when it involves the growth plate is the Salter-Harris classification. There's types 1 to 9, but types 6 to 9 are very uncommon, so I'll just focus on these 5 today. So type 1 is a transverse fracture through the growth plate. It occurs in about 5 to 7% of fractures, and it's caused by a rotating or twisting force. Type 2 is a fracture through the growth plate and metaphysis, which is the most common and it's seen about 75% of fractures, and it's again caused by the rotating or twisting force. Type 3 is a fracture through the growth plate, epiphysis, and sparing the metaphysis, and it's seen about 7 to 10%, and also caused by rotating or twisting force. Now type 4 is a fracture through the growth plate, metaphysis, and epiphysis, and it's seen about 10% of fractures, and this is caused by compression or crushing force. And type 5, it's quite uncommon, seen less than 1%. It's a compression fracture of the growth plate and caused by compression force, crushing force, or osteomyelitis. So what to look for when a child comes in with a possible fracture is pain, swelling, tenderness over the area, not being able to weight bear, limited range of motion, obvious deformity, and if the fracture is a Salter-Harris classification, so it's involving the growth plate. It can lead to growth arrest if not diagnosed and treated quickly. So management, you want to get multiple x-ray views of the fracture and unaffected and the corolateral limb. You want to get CT, MRI or orthopedic referral if not easily classified. Type 1 and 2 usually only need a closed reduction and cast immobilization, but if closed reduction is not possible, don't keep trying as you'll cause more injury than needed. Type 3 and 4 usually need open reduction and internal fixation, and these fractures need to be reduced in ED or orthopedics within 24 hours as the bone reunites quite quickly as they are children and they have quicker healing and can heal in misalignment. So indications for an open reduction or the mnemonic no cast is if it's got non-union, it's an open fracture, it's neurovascular compromise, there's intra-articular fracture, it's Salter-Harris 3, 4 or 5, there's polytrauma, there's failure to reduce a closed fracture, as I was talking about in type 1 and 2, a pathological fracture, and they're paraplegic. So pathological fractures, they're defined as fractures in a bone that is weakened by underlying abnormality. So these are patients with tumours, rickets, McEwen-Albright syndrome, juvenile osteoporosis, chronic renal insufficiency, osteogenesis imperfecta, and osteoporosis. They're all at greater risk for getting a fracture. OI is the most common metabolic bone disorder that causes pathological fracture in children. It's a rare genetic condition. It's categorized by fragile, brittle bone that break easily, and it's estimated to be seen in about 1 per 20,000 births. So general pediatric fracture management. So before you have any medical help, you can always give analgesics, immobilize the joint, apply ice and elevate the limb. Then the further treatment once at hospital would usually be reduction, whether it's closed or open, stabilization with external partial cast or cast, internal with pinning plates and rods, and then rehabilitation to avoid stiffness, preserve the joint movement and improve muscle power. So the initial goals of care in children with suspected fracture are to identify and treat neurovascular compromise, identify open fractures, provide analgesia because you don't want them in pain, and provide immobilization. The following would prompt for a consultation with the orthopedic surgeon, which is neurovascular compromise. It's an open fracture. It's difficult to, it's anticipated that it's going to be difficult to reduce. And always in a child, you should determine what type of fracture is, degree of displacement, and the age of child as it changes the management. With complete fractures in children, they initially require closed reduction. If adequate closed reduction is not achieved or cannot be maintained, they may need operative treatment, particularly if the child is over 10 years of age. With immobilization, a cast may be used to maintain reduction of a green stick or complete distal fracture, and all complete fractures warrant follow-up with orthopedic surgeon with pediatric expertise within 7 days after splinting or casting. So with any child that comes in with a fracture, you should always be worried about abuse, and this is something you can see through whether the mode of injury aligns with their history, and whether the type of fracture is aligning with their age. So these are, wouldn't to worry if they have a skull fracture. So skull fractures are the common skeletal injury leading to diagnosis of child abuse. Skull fractures are extremely uncommon and uncomplicated short distance fall, i.e. falling from a cot. You should also worry if it's a non-parietal bone fracture, it's multiple complex, widely separated and depressed fractures, and a fracture with significant intracranial injury. With ribs, 90% of abused children under 2 years old have healed or current rib fractures in abuse. Posterior rib fractures is highly suggestive of abuse because they are very rare in CPR in children. there was a study that showed that of the 923 children, they had 0 posterior rib fractures. With lower limb, so mostly fractures occur in the femoral. Mid-shaft fractures are inconclusive. There's equal rates seen in abuse to accidental scenarios. You would be more worried if it was a spiral fracture, and you see more femoral fractures in abuse occur before they're walking, so they shouldn't be using that limb yet. With the upper limb, majority of accidental humeral fractures in children are supracondylar, and most common abusive fractures are spiral or oblique. There's no particular type of forearm fracture that is indicative of abuse. You just look at it as a whole, see if it lines up with the history. So, as I was saying, the most common fractures are in the long bones, the kind of tibia, femur, humerus. Diaphyseal fractures are more common in abuse but you can get the classic metaphyseal lesion as well. Metaphyseal fractures are more common, seen around the knee and ankle, and with shaft fractures in abuse, it's 50% seen in the middle third and 41% in the distal third. And thank you for listening to this presentation.